Good morning or afternoon, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy, all the way from Ibadan, Nigeria. Dr. Murphy, how are you this morning?
Doing quite well. It's very warm here, 95 degrees. So
Trying to stay cool. But Dr. Robert Murphy is the executive director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week here on the Havey Institute's Facebook page. Today, Dr. Murphy, will be addressing the latest headlines, answering a viewer-submitted question, and looking at the latest U.S. COVID statistics through today, May 3rd. We invite you to submit any questions you have down below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. For a brief look into the updated COVID statistics, average new hospitalizations per day, 802 this week compared to over 2,000 in the same week in 2023. And average COVID deaths per day were down to 33 compared to over 200 in the same week in 2023. Dr. Murphy, your reactions to those numbers?
yeah, so as was predicted by every epidemiologist, basically, this is the end of the respiratory disease, infectious disease season. So we're going to see downturns in COVID, RSV, and flu. This is a seasonal thing. We know that's happening. But still, 33 people a day dying from COVID ends up being 12,000 people per year. That's still, bad, because this is on top of everything else that had already existed. But the numbers are going in the right direction, and soon the hospitalization for COVID are not going to be reportable, and so we won't be reporting them. We'll just comment on the death rate and see where that goes. Now, there's a couple ways this could pan out. If you think back to 2021, we were in a very similar position in that the rates came down after the respiratory illness season, and things got pretty normal there at the end of the spring and beginning of summer in 2021. I don't know if anyone remembers. That's when things really started to open up. And then what happened? Delta came, big spike in August, and this started another whole stampede of infections in 2022 and 2023. So now in 2024, what's going to happen? We don't know. We'll see. People don't know. People think COVID is not going to really go away. It's going to be one of these endemic things like flu. But we'll see. In the big pandemic in 1918, after 3 years, that pandemic did go away, but flu stayed around. So I think it's most likely going to follow that pattern, just because it's happened before with another virus in the same sort of behavior mode. But only time is going to tell. We just still really don't know enough about it. But these numbers are very encouraging. And the reason why are these numbers so much better is because there's so much more immunity in the population. This is worldwide. So many people have had COVID, and so many people have been vaccinated. I mean, there's billions of vaccine doses have been out there. That's helped considerably, and people are still taking more. And if you are at risk, you really need to take the vaccine. Everyone should be taking these boosters. So now when you get your booster in September, you can get flu and COVID together. And we talked about it before, but getting them together actually gives you a better COVID response than if you split them apart. So if you can put up with the side effects of both of them at the same time, you should probably get it together, and that it will be, a new vaccine.
Mm-hmm. And we do have a little note on that later in the episode, but we did have a great question today from a viewer They were
Mhm.
wondering if cities like Chicago report area level contagiousness of viruses in the wastewater. We talk about wastewater a lot on here and monitoring. If federal or local authorities do that, is there a website where we can find that information?
Yeah, there's several websites. So let's just start. So there's the city of Chicago. They have a very nice one. Thank you, Katie.
Mhm.
They have Cook County and the state of Illinois and the Centers for Disease Control all report COVID and flu and respiratory syncytial virus. And these websites are not all in the same place. So to find them, you've got to kind of go all over the place. So what do we have here? This is the COVID-19 water sampling. And you can see that there are plenty of neighborhoods where this is being sampled. So around the Cook County area, in Chicago and Cook County area, and the state and the country. But this is just from the city of Chicago, I think. And you can see that if you look at that wavy line there in the middle, you can find that it's trending downward. So this is just a nice little marker about how much disease is out there in the general population. So um, trending down. So that's great.
Yes, and to find any of these sources, I would look for the City of Chicago COVID-19 wastewater monitoring. Or if you're interested in other diseases, you could go to the CDC's website. You could look at their flu view page or their RSV net page. They also still do COVID wastewater sampling. So there are a lot of things out there, but as Dr. Murphy said, they are a little bit difficult to track down because they are in different places.
Yeah,
But
so
yeah.
respiratory RSV and flu have their own kind of websites and graphs and stuff, and you do have to look around, but it is out there, and you can always start with the city if you're from the city. I mean, anybody can look at it, but the city of Chicago you can start with. You can then maybe go to this county or the state, and then if you want to see what's happening in the whole country, go to the CDC website.
Absolutely. Great advice there.
Mhm.
Moving on to our first story of the day, we have been talking about H5N1, the bird flu, for the past several weeks, as there was a human case and many infections in dairy cows. Now, there have been completed tests from the FDA on the pasteurization process. Can you tell us about those results, as well as where we stand generally with this
Yeah.
pandemic?
Well, actually, since last week, there's been a few more reports out there. And, why are we worried about this? Well, we're worried about it because avian flu kills most of the birds that get infected and maybe half the cats that get infected. So, a couple things. It was reported recently that fragments of avian flu virus, it's influenza H5N1, that's avian flu, or bird flu, it's all the same thing. So they found that with the polymerase chain reaction tests called PCR, they can find fragments of the virus, but that doesn't mean it's an infectious virus. It's only a little part. The test is so good, it picks up these little fragments. And of course, it was like big concern. In all this milk, it was in quite a bit of the milk, by the way. However, remember, milk is pasteurized. You can buy it unpasteurized, which is highly not recommended, especially now. But if it's pasteurized, most likely, we thought most likely it would be non-infectious, and we haven't seen big outbreaks because of this infected milk. We know that pasteurization works when they pasteurize eggs that are sold, and that's even at a lower temperature. And milk is pasteurized at a higher temperature. We know that all the influenza viruses are pretty fragile, so they're susceptible to heat. So anyhow, this is good news. No infectious virus has been found in pasteurized milk in Europe or in the United States. So I would have to say at this particular point, the milk is safe that we know of. Now, but we've been looking in now the cattle that have all this, and the cattle aren't, a lot of them are infected. Now, they don't seem to be having as a lethal problem with this like the birds or cats. was reported from the University of Arizona that you know cattle have been infected for quite a while, so it's probably been in that. Now, the milk is safe, and we're under testing, but that's improving. And the one thing of concern that has a plus and a minus side to it is that many dairy workers have been getting flu. Most of them are not being tested for avian flu. They're just being tested for flu. Just flu yes or flu no, or just clinically they have it. Now if a lot of them are afraid to get tested because if they're afraid if they have avian flu, they might, get rid of their whole herd of cows, or there's going to be some disaster or whatever. So there's an incentive not to get tested. There's no big increase in mortality among dairy workers, but we really don't know what's going on with them. So it really has to be studied in a rational and reasonable way, because in the humans that have gotten avian flu, the death rate is between 10 and 40%, 40, 50%. So, but that's not really the death rate. That is just what's been reported in kind of just anecdotal reports. So it has to be studied appropriately. And still to this date, no transmission human to human. So if that happens, we're in a lot of trouble. But as we talked about before, there's several companies that are making vaccines for avian flu just in case it starts to be, it mutates to the point where it can transmit human to human. So, and that a nice backup plan, but of course, the best thing is to avoid it in the first place and figure out really what's going on.
Definitely a story we will keep our eyes on for a long time as information keeps coming out. So we will continue to share the H5N1 updates. But on another note, switching gears to RSV, research published this month compared respiratory syncytial virus, RSV, to influenza, different flus, in elderly patients over a course of 7 different epidemic seasons. So this is a very long-term study. And they wanted to analyze the virus's mortality and morbidity. Can you tell us kind of why they were doing that and what they found?
Well, there's been, now we used to not talk about RSV very much, except in like transplant patients and immunocompromised patients that had RSV pneumonia. And it wasn't really in the lexicon, so people just didn't talk about it. But now, because we're testing so much for COVID, we started testing for everything or more things. So the ones that can really hurt you are COVID, flu, RSV, and streptococcus. That's bacterial pneumonia. So RSV has gotten a lot of publicity lately, and it turns out, and these studies are confirming it, that it's a worse disease. In other words, people are sicker. They have more symptoms. They have symptoms for a longer period of time. More of them end up in the hospital. More of them end up in the ICU. The hospitalizations of RSV patients compared to influenza patients, the flu patients, is longer. However, if you look at the death rate, it's the same. So you're sicker, but the mortality is the same as with flu, which is bad. But in all these studies, it looked like it was just as bad as influenza. The thing in the United States, when you end up in the hospital, and you get supportive care and treatment, you can do pretty well. So, and that's actually what we're seeing here. Even though RSV is a worse disease, the treatment that people get when they get sick, and this is kids and adults, is pretty good. And, so many people do survive it. And comparing flu and RSV, it's as far as dying from the disease, it's the same.
Yeah, very interesting research coming out there. And now for the quick COVID update we kind of alluded to earlier. The
Mhm.
WHO actually announced this week which variant they recommend targeting the next round of COVID vaccines against. Can you tell us which strain and why?
Yeah. So with flu, I think everyone is familiar that you get a new vaccine every year. It's based on what's circulating in the southern hemisphere and is likely to come up in the northern hemisphere. And that's what we design those flu vaccines for. So what's happening now with COVID worldwide is there's a shift to the JN.1 variant. The current variant is the XBB 1.5. And so what the WHO has recommended is that the next vaccine should be geared to the JN.1 because it's taking over. And you're thinking about the future. So XBB going down, JN.1 going up. So for the fall, when you get your new flu vaccine and your new COVID vaccine, it's going to most likely be the JN.1. Now, the FDA is meeting on, I think, May 16th to determine if that's what they're going to do in the United States. But the WHO has already committed to moving in that direction. And we think the FDA will probably follow suit. It just makes sense. So, like I said before, in the fall, when you're offered a COVID and flu vaccine, you will get a new COVID shot based on JN.1 and your new flu vaccine. So, and you can actually take them together. And as we talked about a couple of weeks ago, if you take it together, there's actually a nice study that shows that the COVID response is even better than if you split them apart by a couple of weeks. Strange. Don't know if that's clinically relevant, but it's just a good finding and encouraging that not only is it safe to take them together, it's more convenient to take them together. It may actually even work better when you take them together. So it's just something to think about. And then it saves you all the time of going twice and scheduling appointments with your pharmacy or pharmacist. And so that's what's going to happen most likely this fall. We'll report on that when the FDA actually makes their final statement in a couple of weeks.
Absolutely. I was just going to say we'll check in with the FDA in a few weeks. But our final story today is a little bit different, not something we've talked about yet. But recent reports of the US's handling of hepatitis C are not flattering to say the least. Can you tell us a little bit about hepatitis C in general and who is most at
Yeah.
risk in this country for getting it?
Yeah. So hepatitis C, we used to call non-A, non-B hepatitis. And then they found out it was C. So it's hepatitis C. It's an RNA virus. And it causes a lot of trouble if it's not treated. I mean, it takes many, many years, but people get cirrhosis, really sick, and die from it, getting liver cancer. I mean, there's all sorts of terrible things. It costs billions and billions of dollars a year in the treatment of the sickest patients. So anyhow, 10 years ago, there was a drug released by Gilead that was just a blockbuster. And that has taken over the market at this particular point. There are some other treatments out there too, by Abbott and others that work just as good. And it's curable. This is a disease that you treat for 8 to 12 weeks, and you get cured. Like it's gone forever. Now, if you already have damage to your liver, that doesn't fix your liver. So you want to treat it before your liver gets really impacted. So it's just like this fabulous blockbuster, incredible treatment that came out. So why isn't everybody on it? Okay, everybody's not on it for two reasons. One, it costs a lot of money. The companies are charging quite a bit of money. That may change because there is some competition in the wings here that may come out that can significantly lower the price. Billions of dollars have been made off these treatments, and it's time to have a big public health effort to do it, to use it. Now, there's the biggest populations for hepatitis C now are people who are imprisoned, people who are homeless, and people who are uninsured. because this is because of the cost. The cost is just astronomical. So if we can focus on those groups, get them treated, we could save something like $18 billion in healthcare costs. I mean, this is, if you look at the long run, it's great. If you look at the short run, okay, you got to pay something for these drugs. But in the end, you save so much money. So, many other medical systems, they take the long picture. They look at the long run. So this is a good investment. But here in the United States, with our fragmented healthcare and insurance plans and government plans and all these plans, there seems to be no coordination or very poor coordination in getting this treatment and cure to the people that have the disease. Now, countries like Georgia, the country, not the state, has had a national program, and I think pretty much everybody's cured. Egypt is like had a real big problem with hepatitis, and they having fantastic results there. And we can go country after country after country. The countries that have actually recognized it as a problem and implemented a treatment strategy have done like super well. In the United States, we have not done super well. In just the last year, only 34% of those that were infected got treated. It's only 1 out of 3. We have countries up to close to 100%. So what is going on here? So this is just another kind of failure of the system, the public health system in the United States. Some places do it great. New Mexico is doing fantastic with it. And they don't have the best health metrics, but they're fantastic with hepatitis C. But other states, really doing poorly. Even if we just looked at the prisoners, we could cure 90,000 people, in the next 6 months. So it's unfortunate, but that's the way it goes. And hopefully we can deal with this in a better way. There are groups advocating for the elimination of hepatitis C, and we don't want this it's costing us in the long run. And hopefully that we can implement strategies to finally get this thing done. It's totally doable, and the prices are coming down, and they can be negotiated.
Obviously, you can't force people to take medicine. However, especially in the correctional systems, those who are inmates are almost 9 times more likely to be diagnosed with hepatitis C than those who are outside. And it's just a horrible issue.
Well, the other problem in the prisons, if they're not there for 8 to 12 weeks, they got to finish their treatment on the outside. So there has to be a nice system. Now, some jails have set that up, and they have that system in place, and that's terrific. But as a country, we're not doing very well. That is really the way to go. I know also, some of the prisons are run by private companies, and I've been consulted to advise the patients as a patient advocate to get treatment. And of course, they don't want to pay. But there's got to be some other way for that payment to be made, or the drugs to be procured, or something. Because that shouldn't be the obstacle. We should use the prisons as a source to treat many of the people that are untreated right now.
Yeah, very a tragic issue going on, and could lead to a lot of suffering for the general public, people all over the place. But on that unfortunate note, we're going to wrap it up for today. Dr. Murphy, thank you very much for your expertise, for breaking these down for us. We will keep up to date on these topics to make sure that we are all informed.
Well, thank you very much, Katie, and have a good weekend. And we'll meet again next week on Friday.
Absolutely. So we'll see you all again next Friday. Thank you all for watching. If you have any questions, please feel free to leave them down in the description. We have all of our social medias that you can contact us, and we look forward to hearing from you. Have a great weekend.